See, halfway through the program, if somebody decides to undo that, is there a way they can come out of it? And second thing is, have people faced any medico-legal issues because the treatment didn't work or something like that?
I'll answer the first question first. Most of them are very clear of what they want, so the backing of the treatment is very rare. But if they do want to, with hormone treatment, yes, they can. Because I didn't talk about fertility preservation because I didn't have time. So I have a patient who went on hormone therapy, and after 6 months, she said, I want to store my ovum. So she actually went for a gender egg retrieval in Erode, in gynecologist in Erode did the egg retrieval for her. So him. So we stopped the testosterone for 3 to 6 months, the cycle resumed, the ovulation happened, and fertility preservation was done. So yes, with hormone therapy, you can reverse the changes that you have gone through. With surgery, we know it's irreversible change. So usually that's why we don't push for surgery. The guidelines say the surgery has to be talked only after 2 years of being on hormone therapy, just because it's irreversible. With hormone therapy, it's reversible. If somebody says, I don't want to transition, we respect that and we stop that, and most of the changes would reverse back. Medico-legal, yes, we have heard in papers and stuff. Personally, I have not encountered, thankfully, but there is a lawyer. There are lawyers who work with the association. They do help them with medico-legal. You mean for the doctors or for the?
They wanted a particular level of identity for themselves, but medically it couldn't be achieved.
So you mean with the name change and everything?
No, physically. So they must have an image of themselves, like just how the plastic surgery people feel, like that kind of.
I have not come across, but we have read news about that. But that's where a lot of counseling is required. Even when we put them on hormone transition, we tell them what to expect and how long to expect. And I usually tell them that I cannot promise this particular time. We do have all these conversations before. But yes, we have heard from the group that there are issues with medico-legal cases with surgery and even hormone treatment for that matter.
We are very cautious about using hormone therapy, especially estrogen in postmenopausal women, not even going up to 2 or 4 milligram. Now, have you encountered any complication with such a high dosage for a longer time?
Ma'am, longer time, I don't know because I don't have that long patience. So even Gavanda, she's been on, I have patients who are on 3 to 5 years of estrogen. The maximum that I've gone is 6 milligram. I don't go up to 8. But usual dose is 4. I don't go beyond 4 mg of estrogen. Thankfully, as I told you, I have not had any thromboembolism, but I've had colleagues from other states who do transgender care where they have experienced thromboembolism and stroke with estrogen. So, when they do get into this gender affirming therapy, we do educate them about everything. We tell them there is so and so chance, this can happen, we need to follow you up, we need to get the estrogen level, any signs of discomfort you have to let us know. So it involves a lot of talking and educating them up front. But I'm not saying we don't have risk. There's certainly a risk of thromboembolism with estrogen.
But Shruti is again regarding usage of estrogen only. Which estrogen do you prefer?
I can tell you the brand name, Takkanjari. Progynova is what I use.
Okay, but thing is, if you are using a equine estrogen, we can measure it in the assay. We can assay estrogen. And in your talk, you were telling that we do measure estrogen.
I do measure,
but when Pregnova or when this one is given, it won't be detected in the assay, right?
It is detected.
Okay,
Okay. I have never used. I'm sorry, I can't tell the generic name Takkan, don't mistake me. I have never used Premarin. I have used only Progynova all these years. So and I check estrogen and I see the detectable level in the female range. Levels van the 145, 150 and the mid-normal female range la varu. It's not like it's not detected. I titrate the Progynova dose looking into the estrogen only.
Okay. Is there any role for monitoring testosterone in such patient?
No, aldactone podumbodhu there is no much of difference in testosterone levels. It doesn't come down. Only the changes happen. But with GnRH, if that person, the doctor patient I showed you, she was on GnRH. She had a very low level of testosterone even before she went for orchidectomy. I do measure the testosterone level to, not for the alter, just to let them know where they are and everything. So I do check the testosterone level also and keep it in the female range. If they're on GnRH less than 70, as Chitra said, in the female range. But after orchidectomy, I stop aldactone, GnRH, and I don't check testosterone levels.
And regarding that estrogen, even for menopausal hormone therapy, we prefer 17-beta estradiol over this equine estrogen because of a lesser side effect on liver. That's the preferable one. Thank you very much, both the speakers, for excellent session.
Thank you very
Thank the
much,
audience also.
ma'am, for the fantastic session. So actually we've gained 15 minutes. We're still 30 minutes behind schedule, but thank you very much for that fantastic session. So can I request the speakers and the chairpersons on stage, can I request Dr. Anjali Satya to felicitate them, please? Chairperson.